think I'm even shorter than Dr. Murray. The two things I want to emphasize before I give my talk are points that have been made multiple times, but I feel like we should keep hearing them over and over. And the first one is it really has to be an individually based treatment. When Dr. Herford was showing the slides of the number of benzodiazepine prescriptions broken down by benzodiazepines, I believe there were 2 listed for transine. Those are mine. I think if my patients knew that I had 2 patients who are on a benzodiazepine, they'd pass out. And the other thing is not to forget about trauma, because if you can find me one of our patients who doesn't have significant trauma that is just beyond what you can even imagine, please introduce me because I have not met them yet. Oops, this slide got put in the wrong place. So just a quick comment on my outline. I'm going to give some introductory comments. I'm going to talk about benzodiazepine issues, some key points prior to initiating the treatment for anxiety, pharmacologic treatment of anxiety, and non-pharmacologic treatment of anxiety, all in 20 minutes. So this was an interesting experience I had with a patient about 2 weeks ago. He was going to have oral surgery, and we were talking about the pain management afterwards, and I shared with him that I had had some pretty serious oral surgery a year or 2 ago, and that what I had done was taken 800 milligrams of ibuprofen before the Novocaine and all the anesthesia wore off, and how it was amazing. I took that regularly, I didn't have pain, how great it was. And his response was that he preferred a specific opiate because then he didn't care about the pain. And I thought that was a very interesting thought process, the differences. And I think part of that is related to trauma backgrounds about what they're looking for. And I think one really important piece is remembering what is your patient looking for out of the medication treatment, because there may be something the benzodiazepine is giving them that isn't what we realize what they're getting, and we may not be able to replace that. So the patient said, could we up the dosage? I still have feelings. And one of the challenges with trauma is it may be that the reason they want the benzodiazepine is they don't want to feel anything. And often we have patients who are falling asleep because it takes that much benzodiazepine to take away their feelings. So I am not going to talk about how to medically taper a patient off of benzodiazepines. I think we've talked a bit about that. The thing we do have to remember, which has been spoken about, is patients who have a substance use disorder are at a very high risk for misusing and abusing medications with addictive potential. So we have to avoid them when possible. And obviously that may not always be possible, but I think that should be something at the front of our thoughts. The other issue is benzodiazepines, as an example, can be the potential to be addictive. And as it's been commented, it can be lethal to mix methadone and benzodiazepines. And I don't think death is ever an acceptable outcome to relieve anxiety. In general, benzodiazepines in the treatment of anxiety, in patients who don't have a substance use disorder, they're generally very safe. And we often prescribe them because they work quickly and effectively. And in fact, I don't know if other people have had this experience. I have patients who are on benzodiazepines. I'll start them on another medication and give them the benzodiazepine. And I have to beg them to take it. They will take this tiny little pill and cut it into 18 pieces, which I didn't know was possible, and take 1/18, and I'm literally begging them to take the whole pill. And generally, the standard of care is, if we can, if a patient has substance use disorder, to avoid the benzodiazepine because of the risk of addiction. The lifetime benzodiazepine use is reported to be between 66 and 100% in the methadone maintained treated patients. Current use is between 51 and 70%, and that is including agonist, partial agonist therapy, or not in treatment at all. And the estimated rate of abuse or dependence ranges between 18 and 50%, depending on the literature that you look at. So key points prior to initiating treatment, and I really want to emphasize key. So this is how my patients feel when I have the conversation. You know, your therapy will be a combination of drugs and clowns. They often think I am crazy. They tell me that they're not going to be my guinea pig and that my ideas, apparently I should publish some of my ideas because apparently none of you have ever thought of them. Okay, so the first thing is you need to have a strong patient-doctor relationship. That is key. If you don't have that, I guarantee you are going to fail. And you need to make sure, this is I think one of the most important points, is you have to make sure your treatment goal is the patient's treatment goal. So if their goal is to numb their feelings, we're not going to be able to do that. The other issue is you have to make sure you've treated any comorbid medical or psychiatric disorders. You need to promote healthy behaviors, sleep hygiene, decrease caffeine, alcohol. We should generally avoid alcohol at all because they're going to go into withdrawal in the middle of the night and have rebound insomnia. And in fact, the patient, I had one the other day, he was saying, well, I have to have the Xanax. I've taken it every night for 5 years. I can't sleep without it. And I explained to him, basically, after a week on a benzodiazepine, you have tolerance to the sleep effects. It is no longer a sleeping medicine. It's just that he's not anxious about insomnia and he's able to fall asleep. We need to educate patients what to expect. They have to understand that sometimes when you're tapering your benzodiazepine, you're going to get rebound symptoms. That is not necessarily the original anxiety, but this is what's going to happen to most people if we put them on benzodiazepines long enough and taper them off. You also have to let them know medications that you're going to start, what they can expect from them, and how long it's going to take for them to work. Medication issues. Patients with panic disorders are exceptionally sensitive to the side effects of medications, so you need to let them know ahead of time what to expect. I believe you cannot start low enough, because if they have any side effect, they're not going to want to take the medication you're recommending. I often will start a patient at the tiniest of tiny doses and say to them, when you are ready, then you can increase it to this level. Just let me know that you're increasing it. But I let them have control over when we're going to increase the dose. Make sure the patient isn't underdosed. That's a common reason for treatment failure. I often look like this genius psychiatrist when I get a patient with severe depression or anxiety who is on 10 milligrams of escitalopram, and all I do is boost the dose. And also make sure they have an anxiety disorder and not a substance-induced anxiety disorder. So for example, are they using cocaine and then having panic attacks? So I'm going to talk about FDA-approved options, off-label, and PRNs. So the top 3 medications for anxiety disorders, I'm going to publish this because apparently no one but me has ever thought of this before. So SSRIs. Not all of the SSRIs are FDA approved for the treatment of anxiety disorders, but in general, they're all equally effective. I'm going to talk a bit about how to choose based on your patient, and the problem is they're not 100% effective. In terms of SNRIs, venlafaxine is approved. TCAs have the safety issue. A patient can easily accidentally overdose on them, and so I tend to avoid them for that reason. So things I ask a patient, is there a medicine they've had in the past, an SSRI, that they have found helpful? Why reinvent the wheel? Have they had a family member who's found one helpful? Have they had a friend? And I realize the friend is probably not genetically related to them, but they often have anxiety about new medications and side effects, and it's very helpful if they can go to their friend going, oh my God, my left leg fell off, and the friend can be like, don't worry about it, just go back to your psychiatrist, she'll fix it, it's okay. Is there a second reason they would want the medication? I love if I can find another reason that will sort of increase compliance. So for example, I've had patients who worry they have, premenstrual dysphoric disorder, PMS, and they've heard about Sarafem. Great, if that's the one they want to try, I'm going to go along with it. Medications without supportive data doesn't mean we don't use them, just there doesn't seem to be great data. Mirtazapine or Remeron is often helpful because of its sedating effect. Some patients may like that sedating effect. Trazodone, recall it does have the risk of priapism in men, but again, individual patients may appreciate the sedating effects. Bupropion isn't helpful for anxiety, and for some patients, the stimulant effect can actually worsen their anxiety. The problem is the medications take time to work. So what do you and your patient do in the meantime? So there's 2 things that you're going to do. One is to use PRN medications, and the other is to use non-pharmacologic options. Some exciting new options, gabapentin is one that we use quite a bit at my clinic, and it seems to be there is some evidence that it does work for the more severely ill patients, but we need more evidence. Valproate, there was a small randomized controlled study that showed there was improvement for social anxiety disorder. Pregabalin is something I'm going to start to try with some of my patients because it looks like there's some very good studies for that, and I'm interested in finding out more about that. Hydroxyzine, one of the students once said that you should always use Diracs because she thought it sounded like Ativan and Xanax had a baby. I really like it because it has such a wide dosing, such a wide range of doses. You can go anywhere from 10 milligrams to 100 milligrams. Buspirone, generally, if they've had experience with benzos, I think you're just wasting your time. The atypical antipsychotics, I really do not like them. I think this should be the 10,000th line medicine, if even that. Seroquel now has significant street value. I just don't feel like I can ever say, wow, it's okay that my patient got tardive dyskinesia, neuroleptic malignant syndrome, or diabetes because at least they were feeling less anxious. I just don't think that's a trade-off I'm willing to do. Non-pharmacologic options. So one thing I want to talk about is there's some great options. And I have a slide that was out of place, so I'm just going to mention it here. One of the amazing things, and I want to give kudos to Hank Bates and Crystal Stober at my clinic, we've started doing a very, through the IOP, an intensive mindfulness-based stress reduction program, which actually is a 5-day-a-week program. The 5th day is patient-run. So the patients actually, on their own, voluntarily come and run the group themselves. There is no counselor. And the thing that we found that's just shocking beyond belief is we knew that they all had trauma. There needs to be a new trauma scale. It's a waste of time doing the regular one because they're all going to get like the top 1%. So what is that telling us? But it's really been quite amazing how much the patients, we have one patient who's actually going off to get trained in mindfulness. It's just taken on so much for him. CBT is a fantastic option. It's effective for both generalized anxiety disorder. It's effective in both one-on-one or group settings. One study actually showed that a 5-session CBT plus self-study was essentially as good as 12 sessions for panic disorder, and 71 to 79% were panic-free at 12-month follow-up. We need obviously more studies with our patient population though. Generalized anxiety disorder, psychodynamic psychotherapy, CBT, relaxation techniques. You have to remind the patient they have to practice them. I cannot just tell you, hey, here's how you play tennis, and then expect you to go play tennis. You need to be practicing every day. So if a patient is going to be doing progressive muscle relaxation, relaxing imagery, meditation, breathing techniques, they have to be practicing every single day, 7 days a week, because when they have that anxiety or panic attack, it has to be an automatic thing. They have to know how to do it without even thinking. And that's, I think, often why patients say, oh, it doesn't work, I tried, it doesn't work. Well, yeah, if the only time you try it is in the middle of a panic attack, it's not going to work. So, conclusion, anxiety disorders are very common in the methadone-maintained patient. In general, there isn't one. I describe it to my patients as a whole pie. I say to them, look, I can't give you a whole apple pie. That's one thing. But what we can do is we can make a pie up of all these different slices. And one slice may be the medication, one slice may be what they do at home, one slice might be their one-on-one therapy. And so the idea is, how are we going to build up that pie? And the other thing is, we have to hold on to belief for our patients until they can believe it for themselves. And I often find that alone is such an incredibly therapeutic thing to say to the patient is, look, I know right now that you are unable to have hope for yourself, so I am going to have hope for you until you are able to do it for yourself. Thank you very much, and do I have time for questions?
Abby, are you familiar with cranial electrical stimulation? It's a technique I've recently run across where it sounds like hocus pocus, but there's evidently some data behind it, where basically it's a low electrical stimulus produced by a transistor radio battery. Evidently, it's been shown to increase some of the neurotransmitters and lead to decrease in symptoms that's kind of indicated anxiety, depression, and insomnia.
You know, I haven't heard about it, but my patients think I'm crazy right now, and I just imagine if I brought that in. But no, I do think, I mean, I'm just thinking, for example, they're now doing the, I'm going to get it wrong, what's the transmagnetic stimulation instead of as a replacement for ECT?
TMS, yeah.
And I'm just wondering, is it based on basically the release of endorphins and dopamine, if it would be the exact same thing? And I think it sounds really interesting, but I know absolutely zero about it.
I'm going to send you some information.
That would be awesome.
I'm working with a group, there's a company, Fisher Wallace in New York, that they sell this unit, and he's actually done a study at Phoenix House in New York where that showed that they were able to maintain patients in treatment longer who did this. It's interesting stuff, and when I first heard about it, I thought about use in a program. But.
Yeah, no, that sounds really interesting. And just as a quick thing, I didn't have a slide. I have absolutely no relationships with any pharmaceutical companies. I forgot to mention that, but I have none.
Dr. K, I had a...
Thank you, yes.
Dr. K, I had a question, two-part. Actually, one of the problems I see in benzodiazepine use is medication not matching diagnosis. diagnoses. We see bipolar disorder or depression, but mainly prescribed anxiolytics for the patients. And we're trying to get reassessments done, reevaluations of medication appropriateness. The other part is in the treatment of, in those reevaluations, say bipolar disorder is the actual diagnosis, and trying to treat either a comorbid anxiety or the anxiety that's part of bipolar. How would the SSRIs be a difficulty in that?
Right, so the first thing is, with respect to bipolar disorder, we have to be very careful of the diagnosis. I sort of joke to my students, for every 100 patients that come in and tell me they have bipolar, one does. It amazes me how someone saying to a doctor, I have ups and downs, gets them diagnosed with bipolar disorder. So the first thing is, you have to make sure that they really do have bipolar disorder. So let's assume now that they do have bipolar disorder. If they do have bipolar disorder, the first thing is, as I mentioned, is the bipolar disorder has to be taken care of. I don't see, to try and address the anxiety before then, I think would be very challenging. And you can use these medications for someone with bipolar disorder. You just have to be very, very careful. And I think it needs a patient who will work closely. And I think this would be a patient that I think it would be rather challenging for the primary care doc to be the one trying to do this. I think this would be a case where if a primary care doc had this patient, that I would refer them out to a psychiatrist. But yes, they are very challenging. I think I can take maybe one last question.
Can you hear me now? Yeah, you can. Very nice presentation. Just a quick question about pharmacogenetics. Because of some of the shared P450 systems, I'm wondering whether or not genetic testing, because of the polymorphisms, are associated with some of these drugs you're using for psychiatry. What's the current state of the art in testing for polymorphisms?
Yeah, so in general, there are, there's only one that I know of psychiatric drug right now that requires the pharmacogenetic testing. I think, is it carbamazepine? Which one? I'm trying to remember. It's one that I don't use. There's a, yeah, not that, yeah, that one. So there are one or two psychiatric drugs for which testing is the state of, that's the standard of care. I tend to not, those aren't ones I use regularly. I was actually just saying at lunchtime, my guess is in 50 years, maybe sooner would be great, that we know genetically the difficulty, for example, with smoking. It is easier or harder to quit smoking based on your genetic makeup. It's amazing to me how that's a genetic thing. And I suspect what we're going to find out one day is that is true for all substances of abuse, which is why there's some patients who are able just to get off of opiates without any effort, and there are other patients who, no matter how perfect they are, they can't get below 5 milligrams of methadone. So I wish we had more sort of the genetic testing, because I think that is a big issue. I just think, unfortunately, we're not there yet. But I really hope people do more research in that area.